Hello, everyone. My name is Rachel Vreeman. As she said, I'm the director of the Arnold Institute for Global Health at Mount Sinai in New York. And it's really my privilege to be here today on behalf of quite a large number of clinicians and researchers and, of course, youth from across our global cohort. I am going to present this baseline description of the Adolescent and Young Adult Network of IeDEA, which we call AYANI. This is a proverb that has become somewhat of a motto for us in our work, particularly in my own work in partnership in Kenya, where I've worked for over the last 20 years. The proverb goes, if you want to walk fast, walk alone, but if you want to walk far, walk together. And of course, this is something that we consider as we're working on this journey of trying to support children, as Annette was describing yesterday, from infancy all the way into adulthood. It's also something we consider with our institutional partners across global settings. And I think not only as we consider these cohort data for adolescents and young adults living with HIV, but also as we think about how our cohorts and even the combined scientific community of this HIV Pediatrics meeting over the last 15 years helps us to really understand how we can do this, and it takes all of us together in that. So many of you are familiar with IeDEA, but IeDEA stands for the International Epidemiology Databases to Evaluate AIDS. It was established in 2006 by the United States National Institutes of Health as a resource for globally diverse HIV-related data. And it's really quite a large observational database that currently includes global data for over 2.2 million people living with HIV. AYANI was born out of this IeDEA observational database as a relatively new addition in which we have launched a prospective subcohort of adolescents and young adults. In the course of routine busy clinical visits, the kind of visits that contribute data and have contributed data over these years since 2006 to the IeDEA database, of course, we're often not able to collect information that we're really interested in these days, things like mental health and substance use and so on. And so in AYANI, we're trying to do in-depth assessments for some of these domains that are not routinely captured in typical clinical visits in resource-limited settings. We've also added biospecimen collection onto the visits for these adolescents and youth to ensure that we have data for things like viral loads, to test for pregnancy, to evaluate substance use, and so on. And in this cohort, we use culturally and developmentally adapted, but also standardized measurement tools where available. I'm excited to be able to describe the initial results from this cohort's baseline assessments. We are continuing prospectively and hope to be able to describe much more over time and in the future as we document ongoing information about the details and changes in these adolescent and youth social environments, comorbidities, their care engagement, and care outcomes. We're currently conducting the 12-month follow-up assessments for this new cohort. Does have a bit of a delay, doesn't it? So here are the eligibility criteria for the cohort. So these are adolescents and young adults who are living with HIV. They needed to be between the ages of 15 and 24 years at enrollment. They're on antiretroviral therapy. All of these adolescents and youth were considered disclosed with full knowledge of their HIV diagnosis at enrollment. They needed to be enrolled in care at the site and have at least one clinic visit in the prior 6 months. We have been enrolling both perinatally and horizontally or more recently acquired HIV-infected youth. But we have done intentional sampling to ensure that at least 60% of the cohort reflects perinatally acquired HIV. That's particularly because it's very much reflecting what this global cohort looks like overall in terms of an aging cohort of primarily perinatally infected youth. Each region of IeDEA participating is enrolling at least 50 youth for this baseline launch. You can see here the 15 sites across 6 geographical regions of IeDEA that are participating in the cohort, ranging from, on this map, on the west side, from Honduras and Haiti, in Central America and the Caribbean, South America to West Africa, Central African sites, Southern African sites, East Africa, and sites in Asia Pacific, which include Thailand and the Philippines. We are doing annual data collection for this cohort, currently with plans over the next 5 years, where the participants are answering questions to quite comprehensive questionnaires, as well as undergoing biospecimen collection of blood. We're collecting dried blood spots and urine. And then we have the ability to combine these very rich data from the prospective assessments with the ongoing observational clinical data that's been collected over the past 17 years in IeDEA, as well as ongoing. This shows the comprehensive annual assessment measures that we're using. And again, I'm just going to kind of scratch the surface of summarizing this cohort today. We hope you'll see more from these detailed evaluations soon, but we are looking at their general clinical data, including pregnancy, their engagement in care, adherence measures, viral suppression, care transitions, particularly from pediatric to adolescent and or to adult care services, TB screening, evaluations of their social and family context, stigma assessments, food insecurity, alcohol use, substance use, anxiety, depression, trauma history, PTSD symptoms, and sexual and reproductive health screening. So, to summarize the baseline results, between September of 2021 and May of 2023, we enrolled 635 adolescents and young adults into the AYANI cohort. You can see the participants enrolled across the regions here. In terms of their socio and demographic characteristics, the mean age for this cohort is 19.8. Just to sort of orient you in time, that means that the average participant in this cohort was born in 2004. So if you think back to 2003, 2004, 2005, for many of the sites participating in this cohort, this actually matches with when initial funding, such as the funding through PEPFAR, was rolled out to begin to provide pediatric HIV care for many of these settings. So these are in many ways the survivors of our early HIV treatment efforts, particularly in the early 2000s that were rolling out around that time, just again to kind of orient with where we are. About 25% of the cohort's under 18. In terms of sex, we have a pretty even split between those reporting female and male, 1% reporting other. 75% of these youth are still living with their immediate family. About 60% are currently in school or another educational program. 19% are employed independently. And 50% in total are reporting low or very low food insecurity, low food security, or are reporting food insecurity on their measures. Looking specifically at their HIV-related characteristics, 83% of this cohort is thought to be perinatally HIV infected. And this is defined either through documentation in their charts of perinatal transmission or by enrollment into HIV care prior to 15 years of age without another documented mode of HIV exposure. Their average age at HIV disclosure was 13 years. Almost 50% of them report missing at least one dose of their antiretroviral therapy in the last month, and 78% of the cohort at enrollment had undetectable viral loads at less than 60 copies. In terms of their sexual and reproductive health in this cohort, 42% reported that they had ever been sexually active. That includes 39% of all of the females and 44% of all of the males. But you can see there, the average age of those reporting sexual activity was 21 years, essentially, for both groups. Of the 265 youth who reported sexual activity, 50% of the females reported ever being pregnant. So almost half of them. And a little under half, but 45% of those who reported a pregnancy were in the non-perinatally HIV-infected group. 10% of the males who had reported sexual activity reported pregnancies among their sexual partners as well. In terms of their mental health, and there's much more we could talk about here, but to summarize, we do see substantial percentages reporting moderate to severe depressive symptoms at 9%, anxiety symptoms, PTSD, each of those, close to 10% on average. Those with one or more of these mental health issues combined represent a quarter of the population, and 12% of these youth reported suicidal ideation within the past 2 weeks. 10% reported having hazardous or harmful alcohol use on the audit measure, and you can see 4 to 11% reporting different types of substance use as well. Only 1% of this cohort was currently on anti-TB medications. I wanted to dig in just for a moment, although again, I could talk about this a lot more, but related to the suicidality that's reported in 12% of the cohort. And actually, I might draw your attention if you're interested in this issue. There are several posters from Thailand, including one of the sites engaged in this, but other sites as well that have some really nice evaluations of suicidality and discussing suicide risk assessment in adolescents who are living with HIV. We did have some variation among our cohort in terms of how suicidality was being evaluated. All of the sites were using the PHQ-9 and including the measure of suicidal ideation on that. But one of the sites was not following up from that questioning with an additional suicide risk assessment that the other sites were using. So there were 19 cases where we didn't have the additional suicide risk assessment following from that. One of the findings that our group has continued to sort of consider and muddle over has been that the majority of the participants who reported suicidality, 74%, did not have comorbid reports of moderate to severe depression. And 61% of them, 44 of the cases, had no other mental health issues reported. So I think it really does speak to the importance in that way of broader mental health screening for these youth. Moving from suicidality and considering more broadly the mental health comorbidities, we did see 9% of the total participants where they had 2 or more of these significant levels of mental health symptoms being reported. So in conclusion, the comprehensive baseline data from this global cohort does reveal some substantial challenges beyond HIV care for the global population of adolescents and young adults reflected in this initial cohort. We see food insecurity, mental health disorders, many early pregnancies, and we also see more missed ART doses and more treatment failure than we would like. Of course, I would argue that these findings really do support advancing more comprehensive models of adolescent and youth care, very much in line with the kinds of services that might support more care engagement, as Dr. Zanoni was describing. We're currently conducting the 12-month follow-up assessments to document changes in these participants' social environment and in these other characteristics, and look forward, we hope, to continuing to carry out more work and reporting more from this exciting global cohort. Of course, acknowledging the many institutes of the NIH that support this work and the regions of IDEA globally that are engaged, including many of you in this room who have been integral to moving forward this cohort on top of the observational cohort. And thanks to all of those involved from across the regions.
Thank you.